We are now going to hear about the PT's role in the treatment of Duchenne, and today I'm pleased to have with us Sarah Lehman. She is a board-certified clinical specialist in the pediatric physical therapy and has been working for Duke Health for the past 5 years. She specializes in neuromuscular diagnoses, specifically focusing on Duchenne muscular dystrophy and SMA as part of Duke's multidisciplinary neuromuscular clinic. She participates in clinical treatment research studies and also enjoys serving as a TA for the pediatric curriculum in Duke's DPT program. When she's not at work, you can find her paddleboarding with her dog or chasing around her 3 young boys. So you're definitely very busy. Thank you for being with us today, and I will let you go ahead and share your screen.
Okay, perfect. So thank you so much for the introduction, Nicole. I'm happy to be here and happy to be chatting with you. So as Nicole said, I am one of the PTs on Duke's neuromuscular team, and we work in a weekly neuromuscular clinic where we see a variety of neuromuscular diagnoses, but one of the main ones we work with is Duchenne muscular dystrophy. So at that clinic visit every week, our patients will see neurology, pulmonology, cardiology, PT, OT, social work, speech, sometimes orthopedic and nutrition, and some other doctors sprinkled in there. But what I'm going to talk to you a little bit about today is the PT's role, so what I do in our typical clinic visit, and mainly focused on range of motion and how to preserve range of motion in that. So first of all, Duchenne muscular dystrophy, why do we stretch? So the primary purpose of a stretching regimen is to really minimize contracture and deformity over time. We also want to allow for maximal symmetry. We want to counteract, imbalanced muscle weakness, and that also can be compounded by static positioning in some of our wheelchair users later on. And we want to fight the fibrotic changes that are occurring in our muscles over time. There's some key points in stretching. So everyone always asks me, how much should I be stretching? I usually tell them you can't really overstretch in this population, but typically I tell my kids 4 to 6 days a week. 6 days a week is a great goal, and then to have like 1 day a week off is totally fine. We want to focus on our joints and muscle groups that are at risk for hypoextensibility, and I'll go over those a little bit more in detail. And we want to make sure that our stretches are pain-free. So as kids get older, they tend to learn the difference between stretch and pain, and we like to educate them on that pretty early on, because usually pain in a stretch is an indication that the stretcher is doing something wrong. For example, if you're trying to stretch your hip flexors and you're getting back pain, then usually that means you are just creating lumbar lordosis and not actually getting a good stretch of your hip flexors. I also like to tell people, if you are getting pain, you tend to not be relaxed when you're getting pain, and it's really hard to stretch a muscle that is contracting. So we want to make sure that all these stretches are pain-free. It's also really important for our stretches to be done preventatively. It's a lot easier to stretch a muscle before it is contracted. It's harder to gain back range of motion than we've lost than it is to maintain range of motion and prevent that loss of range of motion. Ideally, all our stretching is done by a skilled physical therapist, but then it's also the PT's job to train the caregiver or a parent, and sometimes even the patient themselves to do their own stretches. And I always tell people, even outside the Duchenne population, but to really make a lasting change in your tissue and in that muscle, you really need a long duration, low intensity stretch. So if you're able to get full range of motion, but only able to hold it for about 10 or 20 seconds, chances are you're not holding that stretch long enough to be able to make changes in the tissue. So I'm going to quickly run through the muscle groups that we typically recommend to stretch. It might change a little bit throughout the lifespan, and at certain points you'll be focusing on certain muscles, and later on that might transition depending on where you are at in the lifespan of Duchenne. But we are always going to focus on our lower extremities, our upper extremities, and our neck musculature. Those are the big ones. So for our lower extremities, we are going to stretch. I'm going to break these down even further into pictures as well. So hopefully that will help give you an idea. But real quick, the Lower extremities, we're going to stretch into isolated hip extension. So that's really focusing on those hip flexors. Into isolated knee extension, we are going to stretch our IT bands, our hamstrings, our plantar flexors. So that's our ankle muscles. We want to make sure we're doing that with our knee flexed and our knee extended, because there are two different muscles there and one crosses the knee. The posterior tibialis and the plantar fascia and toe flexors. So some of these you've probably heard of and do regularly, and some of them are a little bit forgotten. So we'll kind of run through all of those. The upper extremities are also important to stretch, and that becomes more important to stretch as we enter the non-ambulatory phase of this disease. So things we're going to stretch are our elbow flexors, our forearm pronators, so the muscles that help to turn our hands down, our palms down, our long wrist and finger flexors, our finger extensors, and then we're going to go into a little more detail on some of those intrinsic hand muscles as well, the lumbricals, the thumb adductors. It's also really important to stretch our shoulders, and I'll talk about that in a little bit as well. And the neck is another one that people tend to forget about. So neck extensors, a really, really easy way to do this stretch, and you can do it in almost any position, is to just do a chin tuck. So taking your chin and bringing it down towards your chest. You might, if you do this, you'll feel a little bit of a stretch in the back of your head, and that's what we're looking for. You can do it laying down on your back. You can also do it sitting up. You could do it sitting on your side, laying on your side, excuse me, as well. And then it's also really important to focus on rib cage mobility and expansion, which I'll talk a little bit about later. And if you're getting a regular eval by a PT, your PT might find some other muscle groups that are tight that aren't on this list, and that would also be important for you to focus on. So I'm going to break down the big ones with some pictures here. And I just want to preface by saying there are a million modifications to almost all of these stretches. So if you find that a way that I have pictured, you can't get into that position, or it's too intense of a stretch or not enough of a stretch, definitely put a message in the question box and I can help to modify a way that can help get that stretch for you. So the first way is to stretch out our hip flexors. I find that the easiest way to do this is lying on our side. Sometimes my younger kids can also do this laying on their bellies, but as we get older, it becomes harder to lay on our stomachs, harder to breathe on our stomachs. And also legs are really heavy. So if you have a patient laying on your stomach and you're trying to lift their whole leg up, that can be really hard on your caregiver. So I found that lying on your side is a really good way to do this stretch. So you're going to want to make sure that your knee is in line with your hip, and you're going to pull that knee posterior while using your other hand to block the pelvis. Again, this is when we want to avoid arching of the back, so that lumbar lordosis. We want to make sure that we've got a flat back and a neutral spine here, so they're not pulling and stressing on our back. The knee could be bent or straight in this position. For this stretch, it doesn't matter. And this patient actually could flex the bottom hip even more, and that would help to intensify the stretch a little bit if we needed more of a stretch, and also helps to kind of balance so you're not pulling the patient and rocking them off the table. From this same position is a great way to stretch our IT bands. So this is a band of fascia that goes from the outside of your hip all the way down to the outside lateral aspect of your knee. So what I'm doing here is, instead of pulling backwards, I'm trying to touch that knee down towards the mat. If you wanted to intensify this stretch again, you could also do it with the knee straight. It just tends to be a little bit harder on the caregiver as the leg gets longer and heavier as well. Again, you're always going to stabilize the pelvis, so we're not putting any stress on the back, and prevent rocking of that pelvis. And again, you can flex that bottom hip for stability. The next one, you guys have probably all heard this and done this stretch, but this is a hamstring stretch. So this one is really important, and it becomes even more important in our non-ambulatory phase as well. It can be done with your leg straight. So this first picture on the left is what I call the straight leg raise position. And the picture on the right is your 90-90 position. So what you can do is either way, sometimes the position on the left, the stretch on the left, can be a little bit more comfortable for the patient. The one on the right can stretch the tendons of your hamstrings a little bit more. So I don't care, either way is totally fine, because you're stretching the same muscles, whatever is more comfortable for the patient. I didn't show in this picture, but sometimes I'm actually going to be up on the table with the patient in order to do this stretch to really block the opposite leg so that you're not getting any rocking or rotation of the pelvis. And then you could also use your shoulder to lift up that leg and get a really good stretch. One other technique that I do to help intensify this stretch is also using contract relax. So if I ask this patient to push her left leg down into the mat table, then what that would do is it would activate the hamstrings muscles. And what you find is after a strong activation of the muscle, you get a better relaxation of the muscle. So that's a good way to intensify the stretch if you wanted to try and get better range of motion there. Okay, there we go. The next one we're going to talk about is ankle dorsiflexion. You're going to do this two ways. So I have two separate pictures of this. We're going to do this with the knee flexed and then also the knee extended. You can almost do this in any position. Here is just seated. But one of the most important things that I like to mention in the stretch is it's helpful to use your forearm to actually generate enough force to get a good stretch here. Sometimes your hand alone doesn't actually give enough force. So using your forearm can help push that toe upwards more. And the other thing I like to mention is right here, my hand is actually helping this patient to maintain their arch muscles. So we want to make sure is they actually don't overpronate and we don't end up stretching with a flat foot. Because then what we can do is we'll actually stretch out some of those arch muscles, and we only want to make sure we're stretching the calf here, not stretching things that we're not intending to. We also want to make sure we're doing that same stretch with our knee extended. And again, you can do this in many different positions. I find it's easiest to do this with your patient laying flat down on their back, but you can also do it side lying. If you do this seated, like for someone who is in a wheelchair, you might also want to recline your wheelchair back. Otherwise, you're also going to get a really big hamstring stretch that might be a little too intense. And the same things there. You want to make sure you're using your forearms to help get a good stretch and make sure you're not overpronating there. The next part we're going to talk about is one that might be forgotten, but we also like to stretch the plantar fascia. So the plantar fascia is some intrinsic tissue on the bottom of the plantar aspect of your foot. And what that does is it helps to support your arch muscles. So sometimes it's just a band that can get really, really tight. So sometimes stretching your into dorsiflexion can help loosen that up, but also combining it with some toe extension can really get that tissue. And again, that one in particular probably becomes a little bit more important when we're in that non-ambulatory phase, and you can easily do that sitting in your wheelchair as well. Next, I'm going to go into a couple of the upper extremity stretches that we typically give out. I'll preface this to say that in our clinic, we do divide up PT and OT pretty specifically into lower extremity and upper extremity. So many of the times it's our OTs that are educating on these stretches. So if you have a specific question about an upper extremity stretch that I can't answer, I will talk to my OTs and consult with them and get back to you. But these ones are some of the basic ones that we'll give. So the first one, we call it the prayer stretch. A lot of times our OTs will use this just as a check-in to see if we even need to initiate a stretching program. So they'll have the patient see if they can get into this position without doing compensation, such as shrugging their shoulders up or extending their elbows out away from their body. And we want to make sure that our wrists get vertical and our fingers get all the way extended there. So if a patient has difficulty getting into this position, then we would probably initiate this as a stretch as well, where you're holding it. Similarly, this is stretching the same muscles. This is just doing one hand at a time. Here, I'm actually doing the stretch, but you could also do this as a self stretch where you would rest your hand, your elbow on a table, on a tray, and then pull your fingers back, your wrist and fingers back. You also, here I'm not pictured actually capturing the thumb, but you would probably want to include that as well. Elbow flexors are also really important to stretch. So we want to stabilize the elbow, keep your arm either in neutral position or supinated, so your palm's up. And you're going to slowly extend that elbow into full extension if you can. The forearm pronator stretch is one that, again, pronation is turning our palms down. So we want to make sure that we have full supination. So we want to make sure that we keep our elbows pinned into the side of our body and then gently turn our palms up towards the ceiling. Again, this can be a self-stretch that the patient does on their own if they are able, but later on it's easy for a caregiver to do it as well, and you could also do it on your tray table. The next one is a thumb adductor stretch. So that's pretty self-explanatory as pictured there, just bringing that thumb down so it's perpendicular to the fingers. Again, it could be a self-stretch if you are able. And then a lumbrical stretch. So your lumbricals are an intrinsic muscle of the hand, and as pictured here, so you're gonna actually flex your distal and proximal interphalangeal joints, extend your metacarpal phalangeal joints, keep your wrist in neutral, and then apply overpressure to the top of the wrist. So again, this can be done as a self-stretch just on top of a tray or even on your armrest of your chair in the later phases. That's one I think that a lot of people forget about. And then I talked a little bit about some shoulder stretching and chest wall. So this tends to be one that we focus on in the later phases when patients are in a wheelchair, but also tends to be forgotten about. So we want to make sure that our chest can stay open for posture and for comfort, but also for breathing. So we want to make sure that we can have enough room so that our lungs can expand and get as much deep breath as we can, because we know that lung capacity is already reduced in this population as we get older. So opening up as pictured here, so our shoulders going up into flexion, abduction, external rotation. We can do that at varying degrees of shoulder flexion. So we can do that at 90 degrees, we can do it at 120 degrees shoulder flexion, we can also do it overhead, fully at 180 degrees. We want to make sure that we're avoiding pinching. So any pinching, any pain in the top of your shoulder would be a red flag there for some impingement. And then we also want to make sure we're not just getting this from our back. We want to make sure that it's the shoulder as well as your thoracic rib cage and thoracic spine as well. And another aspect I like to teach some of my older patients as well is if we place our hands on our lower rib cage, and what you're going to do is you're going to ask your patient to take a deep breath in. And as they take a deep breath in, they're actually going to focus on pushing their ribs down and out into your hands. And what that's going to do is just helping us practice to get full, basically, chest wall excursion and making sure we're able to take these full deep breaths. Okay, so that is my really, really quick run through on basic stretching that I'm going to give all of my patients. And basically the most important thing that we talked about is doing this preventatively and starting it at a young age so we can develop really good habits. But where the role of the PT is really expanded is in how we're supplementing stretching and what else we can do besides stretching. So the use of splinting and orthotics is one of the main ways, which again, I'm sure you guys are all aware of, but I'm going to talk specifically about some of the orthotics and the different types of orthotics that we can use. Serial casting is going to be another way that we can supplement this, which I feel like is a little bit less common and less commonly used, mainly because there's less probably providers that do it. Daily standing, so supported standing in adaptive equipment, and then the use of basically your wheelchair as a position aid. Okay, so first we're going to talk about a couple different types of orthotics. So this is one of the most common types of orthotics. So AFO stands for ankle foot orthotics, orthoses. And these ones, at Duke, we use Cascade to make all our orthotics. So they definitely can be made in-house by your orthotist as well, but these are just examples. So this is an articulating brace, and it's intended for overnight stretching. It's called our DAFO 9 Softie. It's one of the first braces that I will actually give to my patients, and I will give it to a patient actually right after they get the diagnosis of DMD. I won't wait until there's any tightness. So they're going to start it preventatively so that they develop really good habits. This brace needs to be custom molded. You can't just buy it off the shelf. It needs to be custom molded to their arch, to their calf, and to fit their foot. It's only going to be worn at nighttime. These braces are not intended to be worn for ambulation. And one of the biggest reasons for that is because we like to allow our kids with Duchenne to walk up on their tiptoes because that helps them to balance. And if we take away that ability to walk on their tiptoes, sometimes that can actually take away the ability to walk earlier or cause falls prematurely. They do make these things called blanket lifter bars. So one of the big complaints from little kids is that it gets tangled in their sheets and they're tossing and turning and it's messing with their sleep. So blanket lifter bars basically elevates your sheets so that you can still wear sheets, but your feet aren't getting tangled and those extra straps aren't getting tangled. And I do tell patients that they can wear them during the non-ambulatory part of their day. So if they're sitting for school or sitting and watching a movie, they can wear them, but just they have to take them off when they get up and walk around. They do have grippies on the bottom though, like if kids need to get up and use the bathroom in the middle of the night. I'm going to talk about the SMOs in a little bit. So this is another type of AFO that I have started using a little bit more additionally as kind of that first brace. So when young kids are first getting that diagnosis and have full range of motion, we can also use this modified leaf spring design to help maintain the range of motion that they have. So we don't always have to use that articulating one that's going to give an aggressive stretch. This one's just going to basically hold you at neutral. Sometimes we can set it to about 5 degrees of dorsiflexion. We found that they're a little bit less cumbersome than the articulating ones. There's obviously less straps and they're really lightweight, which patients tend to like. The angle adjustable AFOs are what was pictured in that last slide that we talked about. And the biggest thing that I hear is just that the straps are a pain in the butt or they're just cumbersome and they're getting stuck in your sheets. So sometimes those aren't our most loved braces, but they are beneficial if we cannot get to neutral. If we are contracted too much, then they can be set into plantar flexion as well. You can also get an articulating AFO, so an AFO with a joint that just doesn't have the straps. They also are a little bit more bulky, but sometimes those are better tolerated overnight as well. And the last one I want to talk about is a 3-piece AFO. So if you picture the Cascade DAFO on the right here, we could have an inner liner that would just be an SMO, so that would just go over the ankle. It wouldn't go all the way up. And sometimes some of my older patients prefer to wear just that SMO liner during the day, and it can help maintain that medial lateral alignment. So we know that without intervention, Duchenne feet kind of transition into what's called a plantar varus contracture. So our feet drop into plantar flexion and then turn into plantar varus. And that SMO liner can help with the varus, so that pulling in. And then if we combine it with positioned our feet on our wheelchair plate, then that can help a little bit with the plantar flexion contractures as well. KAFOs, so knee, ankle, foot orthoses, are not as commonly used in this population anymore, mainly because now with the use of steroids, our patients are walking longer without using KAFOs. But these are basically an AFO that goes all the way up to the thigh. And when we lock the hinged knee joint, they can actually be used for some therapeutic ambulation when we don't have enough quad strength to walk on our own. Usually it's only therapeutic ambulation. You can imagine these are pretty big and bulky, and you're not going to go walk around school or the zoo wearing these, just from the amount of increased energy expenditure that's going to take to move them. The other thing I like to preface with this is there is a risk of falls and a pretty significant risk of hurting yourself, right? Because if our knees are locked and we fall over, we know that our patients with Duchenne's already have decreased proximal muscle weakness, so our hips and our core muscles are really weak. So when we fall, we tend to kind of fall straight over, and there's a risk to hitting our head there. So I always want to make sure it's in a supervised environment, usually with a PT. And they're also really, really tricky to get perfect because of some body configurations, right? So a lot of our kids, after being on steroids for many years, have decreased height, some increased BMI, and then their hips tend to go out in some abduction and external rotation, which just makes it really tricky to get a perfect fit there. We have found is that kids who are using them, though, tend to have a lot of lateral trunk flexion when they're walking, which just tends to help keep your spine loose a little bit longer. So that is a benefit of those. And then again, I'm not typically doing the upper extremity orthotics in our clinic, but our OTs are always recommending wrist or hand splints, basically to stretch out those wrist flexors and our finger flexors. So you can do both at the same time, or you could do just the wrist flexor and have a separate molar pan that would stretch the fingers that you could take on or off. And there's a couple different companies that do those as well. The tricky part about these is when a patient's most comfortable wearing them. You guys probably already know this, but it's hard to wear during the daytime when we're using our hands for functional things like driving our chair and eating and using our phones. So really the best time to wear these is at night. And we found that a lot of our patients don't tolerate both at night. So a lot of times we recommend wearing one and switching. So wearing one night and switching to the other just to have some wear is better than no wear, but really not, we don't want it to limit your function, your ability to interact with the world. Serial casting is another technique that PTs use to help preserve and gain back range of motion. Mainly in our ankles is where this is going to focus on and where we focus on. So stretching out our plantar flexor muscles. A lot of people think that this can only be done in the non-ambulatory phase of DMD, but it actually can be done while you are still ambulatory, and we do this at Duke. So I'm a part of our serial casting team there as well. We have to make sure that our patients still have enough quad strength to continue ambulation. So I won't let a patient leave with casts on unless they can walk out safely and independently. And what we do, we're in the casting process in that picture there, and then what we do is we have the patient stand and we'll put on a cast shoe, and we'll actually wedge their heel up in the shoe, so making a little bit of a high heel so that they can have heel contact when they're ambulating, and that we won't have a posterior loss of balance when we're walking. So this is an option, like I said, for when stretching and orthotic use isn't enough or isn't working. So this is kind of our last ditch when we've lost some range of motion. Our team prefers to have contracture levels less than 30 degrees plantar flexion. Basically, the tighter you are, the harder it is to get you all the way back to neutral. And generally, the younger that you are, the better outcomes we have too. And the other thing that improves our outcomes is reduced time of contracture, right? So if you had a growth spurt and lost 10 degrees of ankle range of motion over the past 2 months, it's a lot easier to gain that back than it is to have when we have 10 degrees of range of motion that's been gone for the past 10 years. So I always tell my patients early referral is the best for the best outcomes. And the one thing that is a little bit of a caveat is we tend to recommend extensive brace wearing after the serial casting process. So in our kids without Duchenne, they're in braces really 23 hours a day. And then depending on how our patient is doing, sometimes afterwards, our kids with Duchenne's will be wearing braces while ambulatory. Sometimes it'll just be at nighttime because we want to make sure that we're not causing any falls afterwards. It does tend to be a long process, so 6 to 10 weeks is kind of our starting point for patients, and it's weekly casting changes. So many of the people who do it have to be, for us, within an hour to 2 hours of our clinic, because it is a weekly visit. That can be a little bit of a barrier. Next, I'm going to touch on real quick passive and motorized standing. So this is mainly to use to stretch out our legs. So this is going to focus on stretching our hip flexors, really our knee flexors, excuse me, and our ankle plantar flexors in a weight-bearing position. And we get to use these pieces of equipment when independent standing and good alignment becomes difficult. Ideally, though, we are initiating this prior to contracture development and also prior to loss of ambulation. We found that the best results are prior to that loss of ambulation. This here pictured is the Easy Stand and Evolve Easy Stand. So it's a crank arm where you crank up into standing, but you also, now I'm sure have all heard of your Promobile F5, where your power wheelchair can also be in a stand and drive position. I've also been told that Quickie has a stand and drive wheelchair as well, which I have not seen. So if any of you use that and love it, please let me know. There's a lot of, not a lot, I will say there is some emerging evidence on power standing in the Duchenne population, but unfortunately a lot of it is, most of it is not randomized controlled trials. Most of it is really, really small sample sizes and more subjective, unfortunately. So just to be sensitive of time, I'm not going to go through all of these, but these are all recent articles that you can reference to see. But basically, power standing is great for preserving range of motion. We want to be standing for at least 10 minutes a day. I usually tell my patients our goal is an hour a day. And there's lots of evidence now that it's improving community participation and mental health and overall independence as well. And these are just the benefits, again, of daily standing. Quality of life, ease toileting, respiratory function, maintaining or improving range of motion, reducing the progression of scoliosis, bone mineral density, which we know is already decreased with years of steroid use, and independence. So in a lot of these studies, it talked about just some cool personal factors that were benefited by daily standing. So for one that I, as a non-wheelchair user, I didn't even think of, but that hearing conversations was easier when you're in a standing position. Just think about being 3 feet below people who are talking. So that was a really cool thing that I didn't even think about. And the last part of maintaining range of motion as a PT is making sure that we're adequately positioned in our wheelchairs. So aside from standing, we want to make sure that we are well seated in our wheelchair. So if those power components there, so power tilt, power recline, power elevating leg rest, are some things that I'm always putting on my wheelchairs, and I'm also, or asking for at least, and I'm also always asking for hip guides, lateral trunk supports, and hip adductor pads, so that I can maintain a neutral pelvis and a neutral spine when patients are sitting in their chairs. So we want to make sure that we are encouraging that symmetry, and we're not adding to the likelihood of scoliosis or adding to the likelihood of IT band tightness by letting patients sit with their hips in legs in hip external rotation as well. So good wheelchair maintenance and monitoring can help also preserve range of motion. So in conclusion, we typically recommend assessment by a rehab specialist every 4 to 6 months throughout the life, and that's a minimum. So typically we're seeing our patients twice a year, and obviously more frequently if there's clinical concern, a change in status, or specific needs. With our younger patients, we do typically recommend more frequent intervention, not necessarily for our clinic visits, but with a PT, because this can help to develop good habits. So we really want to develop that good stretching preventatively. And just overall with this population, we want to be proactive in our care rather than reactive. It tends to be a lot easier, and we tend to get better results. So for my younger kiddos, I'm also helping them to safely acquire age-appropriate gross motor skills, helping them work on their balance, and then hoping to help extend their years of ambulation as well. And then as always, monitoring equipment needs and orthotic needs. Again, this is a lot easier to do this preventatively rather than if I find a patient has outgrown their AFOs and they haven't worn them for 3 months, and then they come to me and it takes a month to get their new AFOs in. Now we're without AFOs for 4 to 5 months, and we can really lose ground and lose range of motion there. That can be hard to gain back. PTs are also a great resource to help keep your caregivers not only accountable, but also just serve as a resource for them. So bright bodies change, and there might be a way to tweak a stretch, tweak a transfer in order to help maintain that range of motion. So kind of my magic solution here is daily stretching, the use of orthotics, daily standing, and the use of adaptive equipment is going to be your best route for preventative care. And that was really fast, but I wanted to make sure I got through everything. So I think there'll be some questions, but you can feel free to jot down my email and my phone number as well if you have questions that I don't get to today.
Thank you, Sarah. That was great. I wanted to see if, stretching you said should be done daily. Is that something that you do all year round? I know some people like to take a break during summer. I've heard that before, or take a break from orthotics.
Yes.
What's your recommendation on that?
Yes, I would rather patients, rather than taking a big chunk off, I would rather patients take off 1 or 2 nights a week. So I do get that we need a break, but if, like what happens if we take the summer off and that coincides with a large growth spurt, for example, then when we reinitiate in the fall, it can be that much harder to gain the range of motion back. And I also think, especially in my younger kids, routine is so important. So if we're really getting out of a routine, it can be really hard, and we'll have a lot of resistance reinitiating that routine. So I'd rather have you cut out 1 or 2 nights, or I've had kids with brace wearing, for example, wear 1 brace and alternate nights as well.
Okay.
I'd rather do that than take off those 3 to 4 months.
Perfect. All right, that makes a lot of sense. We have a question from Irene. She says, my 11-year-old grandson is walking, but is now having trouble with one leg. He has PT in school twice a week. I'm certain they are not as thorough as your presentation outlines. He has never met with a PT as part of his medical team. I would think that this is overdue, and we do not stretch at home.
Yes. Oh my goodness. Yes, you need to see a PT. So it's great that he's being followed by a school PT, but I always tell my parents that school PTs, they have to do things that are educational purpose. So stretching doesn't enhance his education or his ability to interact with the school environment. So a lot of times your school PTs actually can't or won't do stretching. They're really there to help make sure that he can negotiate the classroom, he can get to and from classes as needed, negotiate the playground, go up and down stairs and things like that. So definitely, I would recommend him seeing at least an outpatient PT, but then I would hope that whoever he sees for his neuromuscular care would also have a PT that he could refer them to as well. If it's not part of that clinic visit and part with his neuromuscular doc, then he should know someone like part of our Duke team that can help.
That's interesting. I didn't know that about school PTs. That's interesting.
Yeah, like it's great, but it has to be educationally beneficial. So
very interesting. All right. I do not see anything else that has popped up. So thank you so much, Sarah, for your time.